we will be discussing a very important topic today, which is relevant not only to students of medical, dental, nursing and paramedical stream, but it is also relevant to all general clinicians, and the topic is no-scalpel vasectomy. बिना टाका बिना चीरे के नसबंदी. No-scalpel vasectomy was first done by Dr. Lee in China in 1974. Then onwards it evolved, and in India it was first done by Dr. R.C.M. Kaza in 1992. NSV or no-scalpel vasectomy is gold standard for vasectomy. But before going for NSV, the person has to be properly trained. This NSV is popular permanent method of male contraception. Here by permanent method I mean that it is a permanent method if it is not reversed, but yes, if it is required, reversal or reunion of vas can also be done. What is clicking? The main thing which really fascinates the audience or the clients is that there is no cut, no stitch, very less amount of pain, and then the person can return to his or her his work very early. Now, what are the benefits of NSV? If we compare with classical vasectomy, the complication rate is 10 times lower in NSV. It is a faster procedure. The procedure will take a very short time, and there is less bleeding and less pain. No sutures are required as the name implies, and then because of all these virtues, there is enhancing of this procedure in population. Now, let me tell you about the technique. All the medical persons, they should know about the techniques. This is basically done with the help of two specialized instruments. As you can see in the diagram, that one is extracutaneous vas fixation forceps and one is vas dissecting forceps. The vas fixation forceps is a sort of loop type of forceps. It has got diameter which varies from 3.5 millimeter to 4.5 millimeter if we are talking about the internal diameter. While this vas dissecting forceps is nothing but a mosquito artery forceps, the tip of which has been ground to the shape of needle, and with the help of these two instruments we do no-scalpel vasectomy. Whenever we are doing, we choose the site, the junction of upper 1/3 and lower 2/3 of median scrotal raphe. That is the site, and then we give local anesthesia 2% lignocaine hydrochloride. First of all, approximately 0.5 to 1 ml we raise the wheel at the site where we are going to make a puncture. Mind you, I am not talking about the incision, I am talking about the puncture. Then the needle is directed towards one external inguinal ring and perivasal infiltration of the anesthesia is done. Then the same procedure with the same prick is repeated on the other side. That means we anesthetize the local area as well as both sides area of vas deferens. If you can see clearly in the diagram, then the vas is brought towards the median scrotal raphe with the help of 3-finger technique. What is that 3-finger technique? See, with the help of index and thumb, which is placed anterior to the scrotum, the skin is stretched, while with the help of middle finger, the vas is pushed and it is brought subcutaneous. Once brought, the vas has been brought subcutaneously, it is held along with the intact skin with the help of vas fixation forceps. See, we have not made any puncture as of yet. Vas is fixed with skin. Then this vas fixation forceps is repositioned by rotating it to 90 degree, so that now vas becomes prominent, and then with the help of index finger, the skin over the vas deferens is stretched, so that it becomes prominent. Because it is anesthetized, so this does not have pain to the patient, this does not cause pain to the patient. Then with one blade of vas dissecting forceps, what I told you was the instrument which was like a mosquito artery forceps, the tip of which was ground to become a needle like structure. Then one blade is pierced directly through the skin up to the lumen of the vas. That means you pierce the skin, the deltoid muscle and fascia, the anterior wall, the perivasal sheath, the anterior wall of the vas, and that has to be at 90 degree. As soon as there is a feeling of give way, we remove this single blade. Now after that, we push the vas dissecting forceps with both the blades closed through same puncture in same direction up to same depth. So once you have achieved that, then you open up. You open up your forceps. So what will happen? This vas, which was a round structure, becomes the ribbon like, and the perivasal sheath, it is already dissected, automatically dissected, and the vas becomes bare. Now you rotate, and at this time you are holding the vas with the help of vas fixation forceps. But now you rotate the vas dissecting forceps, and while you are doing that, then you slowly release the vas fixation forceps. Now this vas, the one blade of vas dissection forceps goes posterior to vas deferens, and you lift the vas deferens out of that puncture wound. As you are lifting the vas deferens out of that puncture wound, you have released the vas holding forceps. Now with the help of same forceps, that is the vas fixation forceps, you hold the vas deferens, both the loops of the vas deferens, they are held and the vas is pulled out of the wound. Now you can see that there is a perivasal sheath between the afferent and the efferent limb. Now this is dissected again with the same instrument. The vas dissection forceps is put in between the two loops and it is opened. So as soon as you open, as you can see in the diagram, the perivasal sheath is dissected and vas becomes bare. Now what you do? You ligate both the end, both the afferent loop and the efferent loop with non-absorbable colored suture. Why I am telling you non-absorbable? Because if you will ligate with the absorbable, then the chances of reunion will be more. Why I am telling you the colored one? Because if you require for vas recanalization or vas reunion, then because of the color you can identify the proximal and the distal end. That is how you do. And in between portion you remove and send for the histopathology, so that you can be sure, yes, you have removed the vas. So that you can see you have dissected the vas and you have ligated afferent and the efferent loop with non-absorbable colored suture material, and then after you have done this, you will reposit the vas in the wound. The same procedure will be repeated through same puncture wound for the other side. That means both the sides are taken care of by same puncture wound at the junction of lower 2/3 and upper 1/3 of the median scrotal raphe. A small adhesive dressing is applied, that remains there. So that is all about the procedure. Now let me tell you what could be the possible complication. Initially I told you that the complications are almost 10 times lesser as compared to open vasectomy or the classical vasectomy. But yes, as common with every operation, you can have hematoma, you can have infection, and one particular is sperm granuloma. For the sake of my medical personnel, I tell you what is the sperm granuloma. See, you have tied proximal as well as distal end. Now proximally, that means towards testes, the sperms are being produced and they are being transported through the vas, but they will not be able to pass, move in the forward direction. What will happen? They will collect at the site of ligature what you have placed, and then there will be sort of swelling. So patient may come to you, may say, sir, they have got some knot like swelling at the site of operation, and that will remain there. Sometimes it is painful. The treatment is only reassurance. In due course of time it subsides and then nothing happens. Then some long term complications. Suppose you have ligated the vas difference becomes nodulated, and that is what we mean by vasculitis nodosa. Some patients, they do complain of chronic testicular pain all the time. They complain, yes, since the vasectomy has been done, they are having pain. Then it is very important for you to understand that some persons, they develop anti-sperm antibody. What is that? Like the blood brain barrier, you have got the blood testis barrier also. That means the blood is being separated from testes. Try to understand. Formation of sperm occurs in adolescent age. The immune system development occurs by the age of 5 to 7 years. That means the sperm of a person have developed after development of immune system. That means the sperm, they are like antibodies, but these are separated by blood testis barrier. Once you have done this vasectomy, this blood testis barrier is broken, and this sperm, suppose it goes in the blood, it will create anti-sperm antibodies. So what will happen? Once you are reuniting the vas difference, even if the vas is patent, the sperms, they are not viable. All the sperms are dead. So that is again could be a complication. Then there is auto recanalization. In less than 0.2% cases, the two end of the vas may reunite, and this usually occurs after 2 to 3 months. If it has to happen, 1 in 500 cases, they usually occur within first 2 to 3 months. So suppose you have done vasectomy, that is why the role of the importance of the histopathology is very important. At least you can say that you have done vasectomy and it is a sort of complication, it has reunited, and that can happen, and that is I told you 1 in 500 cases. So in that way you will be medico-legally safe. Then it has been seen that in few cases, even after years together, there is reunion, and that is 1 in 4,500 cases. Now try to understand the importance of this complication. Once the vasectomy has been done, the azoospermia has been proved, male has been declared as a sterile person. Now say after 3-4 years, that couple has got pregnancy. Now what will happen? The male member of the family may think that the wife is not loyal. So before labeling that his wife to be not to be loyal, the person should get the semen examination done, because 1 in 4,500 cases the vas can reunite automatically after so many years. As you can see in this diagram, and this is basically a research which was done, 532 cases of the conventional vasectomy versus 680 cases of the NSV, and you can see the rate of infection is very less, hemorrhage is also very less, and overall complications I told you is approximately 10 times less as compared to conventional vasectomy. There are some myths. Initially, when the NSV came in or the vasectomy came in, it was told that yes, vasectomy increases the incidence of heart disease, vasectomy increases the incidence of cancer, especially the prostate cancer. This National Cancer Institute did a very meticulous study and has proven that it is safe, effective and permanent method of birth control, and it does not cause any heart disease or does not lead to any cancer. So, all the persons who are going for this vasectomy, they should be assured that they should have no myth of all this type. After you have done vasectomy, remember, you have to give post vasectomy instruction to patient in writing. Normally what you do, you give a sort of chart, and that chart carries all the instructions, and that is, as soon as you have done the vasectomy, patient is discharged. You do not keep the patient in hospital, immediately patient goes and then resumes normal work within 48 hours. Even he can drive cycle or the motorcycle after 1 week. Car, the person can drive after 24 hours, there is no problem. But yes, cycle or bicycle, because why? Because it may cause little bit discomfort or the pain. And then whatever medicines they have been prescribed by doctors, the patient has to take. Patient can resume his work as soon as possible. Need not take rest. Suppose patient is a shop owner, shopkeeper, office persons can go home, can go to his work. The operated area has to be kept clean and dry. Of course, patient can take bath after 24 hours, keeping the area of surgery absolutely dry. And as far as the intercourse is concerned with his wife, the client can go for it as and when he feels comfortable. There is no restriction. So, there is no restriction that patient cannot make contact with his wife. But the word of caution is that just after vasectomy, the client is not sterile. See, you have just noticed, I am not saying the word patient, I am saying the word client. He is a normal man, and once you have done the vasectomy, immediately after vasectomy, that client is not sterile. For that, there has to be at least 20 ejaculations or 3 months, whichever is less. So, that is very important for you to understand, and during that period, if the person makes contact with the wife, then has to use some barrier contraceptive. If there is some pain, some fainting or some swelling, immediately the doctor has to be, the client has to go to the doctor, report, and then usually after 48 hours, the client is asked for the checkup, and this azoospermia is checked after 3 months. That means after 3 months you are confirmed that this vasectomy is complete, total, and now patient is sterile, can perform contact without using any barrier. This is very important for you to understand and make the public understand that this vasectomy does not change the volume of semen, because the total volume of the semen, the sperm, they constitute only 3% of the total volume. That means the basically volume is made from the prostatic fluid or the seminal vesicle fluid. So, that is that you are not going to do anything with them. So, that is why the volume of semen remains the same. It does not affect the erections, the libido or the quality of orgasm. That means the sex life is not at all affected. So, there is a myth that after doing vasectomy मरीज को वो नामर्द हो जाएगा, ऐसा नहीं है. It's not like that. Nothing happens. And then suppose the vasectomy has been done and some mishap has occurred in the family, this vasectomy can be reversed. Of course, it is not 100%, but 25 to 30% success rate is there if you do the vas reunion. My dear friends, males have got equal responsibility for family control, and male sterilization is easier than female. You see, in the female, the instrument goes into the abdomen. Here it is just outside the abdomen. It is easier and it is having less complication. But even then, the male sterilization is not very popular. Why? Because there is a myth that once the vasectomy is done, the male will lose virility. It is not that. मर्दानगी खत्म हो जाएगी, ऐसा नहीं है. और they will lose their physical strength. It is all myth. So, that myth has to be removed by all the healthcare workers in the society. Now, question comes, why at all the men, they do not accept this vasectomy? First of all, attitude. I am a man, why should I go? It is a job of female. Female should go and get the tubectomy done. Why I should go? Then the misconception, what I told you, they will become impotent or they will become less productive. That is not there. They are fearful of the complications, of the pain, all these things they deter. So, but as a healthcare worker, as a doctor, as a nurse, as a paramedic, as a technician, it is our duty that we should go into the society and tell that the male sterilization is easier and has got the less complication. After that, there are certain frequently asked questions and you should be able to answer them. Will vasectomy change me my sexuality? You will say no. Will I be sterile right away? Answer is no. I told you, after 3 months or after 20 ejaculations. Will I have ill effects on my health? Of course, no. No cancer, no heart disease, no loss of physical power, no loss of libido or the virility. Will it perfect me from passing through STD or AIDS? That means we have got the vasectomy done. Now I am safe for the STD, sexually transmitted diseases, or HIV or AIDS? No. It is not giving you a sort of protection from those diseases that you have to take care of. And can a vasectomy be reversed? Yes, of course, it can be reversed. So, all these questions you should be able to answer emphatically and with full authenticity. Take home message, just to have a revision, whatever I have told is, NSV is gold standard, I told you, and that has to be followed. It is safe, simple and effective method for permanent male sterilization. It causes less complication, less pain, and it is more acceptable if you accept it without fear. It does not interfere with sexual life or sexual pleasure. It can successfully be reversed if at all it is needed. The person have to take the birth control measures for up to 20 ejaculations or 3 months, whichever is the earlier. They have to prove they have become azoospermic, then they can remove the barrier, whatever they are taking. The azoospermia has to be proved. And then very important, the spontaneous recanalization is a possibility. Usually I told you 1 in 500 within 3 months and 1 in 4,500 even after years, and that has to be kept in your mind. Thank you very much. We all should be united and shake our hands to control the population and serve as well as save our nation. Thank you.